You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 2nd, 2019. This week, digoxin, acupuncture, heart failure with preserved ejection fraction, bariatric surgery, and cardiac device complications. We have to start the discussion this week with digoxin. This summer saw a flurry of activity on an old drug, one that has been much maligned, but I will argue still has a role. To be clear though, my interest in this topic has less to do with the specifics of digoxin and more to do with the overconfidence in observational studies that are used by those who malign the drug. Most observational trials of digoxin, whether for AFib or heart failure, show the same thing. Use of digoxin associates with worse outcomes. Multiple luminaries in cardiology have publicly stated digoxin use should be limited or eliminated, and my senior colleague at my hospital uses a poison symbol on his teaching slides for digoxin. The first paper I want to discuss is from a group in Germany who relooked at the only placebo-controlled head-to-head RCT of digoxin use, ever, one RCT. It was called the DIG trial. New England Journal of Medicine published DIG in 1997. It compared digoxin use in patients with heart failure and a reduced ejection fraction, almost 7,000 patients. Mortality, the primary endpoint, was unaffected. However, one of the secondary endpoints, hospitalizations for heart failure, was significantly reduced in the DIG arm. And a subsequent post-hoc study showed that those with DIG levels of 0.5 to 0.9 actually had lower death rates and heart failure hospitalizations. Crucially, the DIG trial did not include patients with AFib, and 1997 predated the use of beta blockers for heart failure. The European Heart Journal published the German group's relook at DIG. This was an extremely clever analysis. The authors were concerned that much of the bad press DIG receives stemmed from observational data, which they felt is flawed because of prescription bias. Now, prescription bias is a form of selection bias wherein sicker patients get the drug, and that is why they do worse. The authors took advantage of the fact that nearly half of the patients that were going to be enrolled in the DIG trial were taking digoxin at the time of recruitment. That means that in these patients, their doctors chose to use digoxin for them and chose not to use DIG in the other group. Of course, when randomization occurred, a patient on DIG was either placed in the placebo arm or the active arm blindly. Now, the genius of this post-hoc analysis was the authors now had outcomes on two groups. One, an observational group, DIG versus no DIG before the trial, and DIG versus no DIG in the randomized trial. And remember, in the randomized trial, when DIG use was balanced and choice was random, there was no difference in mortality and lower heart failure hospitalizations in the active arm. But it was the opposite when the authors looked at the pretrial use of DIG versus no DIG. Now, patients on DIG before the trial had higher death rates and higher heart failure hospitalizations. Well, why was this? I think it's simple. They were sicker, and indeed, baseline characteristics confirm this. And the hazard ratio in pre-trial DIG patients was about 1.22, which is remarkably the same as most meta-analyses of DIG observational studies. Thus, these authors have shown incredibly strong evidence for selection bias, prescription bias, in digoxin observational studies. Now, Jack published the second important DIG study this summer. Here, multiple authors sought to determine a relationship between stopping DIG in patients in the hospital with heart failure and outcomes. Now, recall that two very old RCTs, Radiance and Proved, that were done before the beta blocker era found that stopping DIG in heart failure patients associated with worse outcomes. The question now, of course, is medical therapy is better. Maybe DIG discontinuation is no big deal. This was an observational study using a Medicare-linked registry. There were about 3,500 patients who were on DIG before they were admitted to the hospital, and 721 of these patients had DIG stopped during the hospitalization. So you know the drill. You can't really compare nearly 3,000 patients to 721, so the authors do propensity matching. And they found About 700 patients from the group who did not have DIG stopped, who, on a spreadsheet of data points, looked similar to 721 who had the DIG stopped. So then they compared outcomes, and similar to the older RCTs, patients who had their DIG stopped did worse. 4 years out, those who had DIG stopped had more readmissions, more heart failure readmissions, and higher rates of a combined endpoint of heart failure or death. The association with mortality was significant at 30 days but disappeared after the first year. And the associations with readmissions from DIG withdrawal became significant at 6 months and lasted for 4 years. So these observational data are very similar to the older RCTs, but of course they're observational, so this data suffers from the possibility of confounding variables. That is, sicker patients had their DIG stopped and that's why they did worse. Okay, so taken together, these two studies, I think, counter the prevailing notion that DIG is a, quote, bad drug. I defended Digoxin in a written column this week, and I hope you take a look and maybe comment on it. Yes, Digoxin has a narrow therapeutic window. It requires monitoring and care. Yes, there are better rate-controlling options in patients with AFib. But in the same way, we should avoid using biased observational studies to make beneficial claims for a treatment. We should also avoid using biased studies to suggest the drug is harmful. In its one RCT, DIG did not worsen mortality and may have improved heart failure hospitalizations. In the two DIG withdrawal RCTs, taking heart failure patients off DIG worsened matters, and a contemporary and rigorous observational study aligned with these two RCTs. The European Heart Journal paper elegantly exposes prescription bias in digoxin observational studies. So I say, let's take the poison symbol off the DIG teaching slides, and if you want to proscribe or ban digoxin use, bring me the RCT showing that it harms people. Finally, remember, the importance of this story transcends DIG. It speaks to the challenge of forming opinions from non-randomized observational studies. Second topic today is equally provocative: acupuncture. This week, the very prominent JAMA Internal Medicine published a provocative sham-controlled RCT of acupuncture for the treatment of patients with chronic stable angina. Sit down for this. Acupuncture significantly relieved angina over a 16-week period. This was a RCT conducted in 5 centers in China. 400 patients with angina were randomized to 4 groups: acupuncture on the disease-affected meridian, acupuncture on the non-affected meridian, sham acupuncture, and no acupuncture. These patients were put on a wait list and promised that they would be able to have it after the trial. The primary endpoint was change in frequency of angina attacks from baseline to 16 weeks as recorded on angina diaries. Secondary endpoints were severity of angina, use of rescue meds, and a 6-minute walk test. All of these patients were receiving angina meds for the 16 weeks, and of note, enrolled patients had a lot of angina. The mean frequency of attacks in the run-in period was 13 per week. The authors observed a greater reduction of angina attacks in the disease-affected meridian group versus the non-affected meridian group. The difference was 4, and this p-value was significant. In the disease-affected meridian group was also better than the sham acupuncture group. Here, the difference was 5-fold, again, significance. And the disease-affected meridian group was much better than the waitlisted group. Here, the ratio was 5.63. Secondary outcomes also favored the disease-affected meridian acupuncture. Well, this is interesting, isn't it? My colleague at the Heart.org Medscape Cardiology, F. Perry Wilson, titled his commentary on this study, quote, "Acupuncture for Stable Angina, Too Good to Be True." Dr. Wilson cited some major weaknesses of this study, and mainly the lack of blinding. Now, patients may have been aware of their group. Since acupuncture is more common in China, patients may have been able to tell the difference between sham and real acupuncture. And also problematic was that acupuncturists knew which therapy they were delivering, which means there could have been a therapeutic interaction between clinician and patient, much like there is after a PCI. Another problem and difference from the placebo-controlled Orbita trial was the author's choice of a less objective primary endpoint. Here they chose reported angina attacks taken from a patient diary. It would have been better, I think, to have a more objective endpoint, say treadmill performance. But despite these limitations, there are some notable points. First, all groups reported less angina, even the waitlisted group who were promised acupuncture down the road. Sham acupuncture reduced angina, as did acupuncture in the non-disease meridian. These 2 points suggest that a caring signal, just being in the study, having acupuncture, whether it's real or not, relieves symptoms. And I think this is not inconsistent with past work on placebo studies. Remember, there's a famous placebo study showing that relief of symptoms even when patients are told they were taking a sugar pill. And I want to vigorously object to 2 criticisms of this study that I've read online. One is that this comes from acupuncture centers, so it must be too biased. And that is ridiculous, because if that is true, the same holds for most cardiology studies. I mean, are you not going to believe Cabana trial because it comes from ablation centers? Or you're not going to believe cancer studies because it comes from cancer centers? The second criticism I object to is that the effect size is too unbelievably large. Saying this implies you understand subjective symptoms. And I'd argue the fact that stenting open a 90% coronary lesion did not significantly improve angina over a sham procedure should reset our levels of certainty about angina. Finally, you remember a few weeks ago I reported on the Vinay Prasad paper about medical reversals. This was in the Open Journal eLife, and their manuscript included the peer reviewer's comments and the author's responses. And gosh, given the provocative nature of this report, it would be of great help if readers could have seen these comments, and I vote for more open peer review. Next topic is another setback in heart failure with preserved ejection fraction. In the rationale and design paper for the Paragon HF trial, which was published back in 2017 in JACC Heart Failure, there is a gorgeous central illustration showing how the combination drug valsartan sacubitril should work in patients with heart failure and preserved ejection fraction. On the left side of this illustration is the natriuretic peptide cascade, and this includes neprilysin, an enzyme responsible for breakdown of vasoactive peptides, which are beneficial. Sacubitril, being a neprilysin inhibitor, blocks the breakdown of beneficial natriuretic peptides, and this has the good effect of decreasing blood pressure, sympathetic tone, aldosterone levels, and it enhances diuresis. So perfect, that's perfect effects. And on the right side of this beautiful central illustration is the renin-angiotensin-aldosterone system, which is excessively activated in heart failure with preserved EF. And of course, valsartan blocks this, which reduces vasoconstriction, sodium and water retention, and myocardial hypertrophy. The illustration, therefore, perfectly explains the benefits of the drug in these patients. Except, this week we learned from a Novartis press release that the Paragon study narrowly misses its statistical significance on the primary endpoint, but they say the overall safety profile is confirmed and the totality of the evidence suggests potentially clinically important benefit. Now, Paragon HF randomly assigned about 4,800 patients with heart failure and preserved EF, and this was defined in the trial as heart failure with an ejection fraction of at least 45%, New York Heart Association class 2 to 4, to receive either sacubitril, valsartan, or the angiotensin receptor blocker, valsartan alone, for up to 57 months. The primary endpoint was a composite of CV death and total heart failure hospitalizations. The press release said the authors of the paper will present the full data set at ESC coming up at the end of the month. And most of my comments will wait until ESC, but here are 2 brief notables. One, Novartis' choice of words that a treatment fails to meet its primary endpoint but overall safety profile is confirmed is classic spin or manipulative language. You should be on the alert for this. Secondly, I'd urge you to look at that rationale paper and see how immensely plausible this drug was for this condition. But in medicine, plausibility is hardly enough. You have to show something works in an RCT. Fourth topic today is bariatric surgery for AF. Now, I like the EP team at Cleveland Clinic. Due to geography, I share a handful of patients with them. Their patients are well informed and they do well. Second, the Cleveland Clinic people are nice people. And third, they publish useful data. So let's talk about their most recent paper in EuroPace. This was a retrospective cohort study of 239 consecutive patients with morbid obesity who underwent AF ablation. The question of their study was the impact of pre-ablation bariatric surgery on AF outcomes. So the primary endpoint was AF recurrence beyond the 3-month blanking period after ablation. And to suss out causality in this non-randomized sample, the authors compared the 51 patients who had had bariatric surgery to the 188 patients who did not. And already you see a challenge. The two groups are way uneven. I will also add that baseline characteristics at the time of ablation, say hypertension, diabetes, and of course BMI, were different. Crucially, the median BMI was 37 in the bariatric surgery group versus 42 in the non-surgical group. So after 3 years, 20% of the patients in the bariatric surgery group had recurrent AF after ablation, compared with 61 patients in the non-bariatric surgery group. And of course, this was significant. Also, they noted redo procedures were less common in the bariatric surgery group. The group of patients with bariatric surgery also had lower epicardial fat volume, better glycemic and risk factor markers. So similar to the Adelaide group, Prash-Sanders' group, AFib recurrence in the larger non-bariatric surgery group correlated with BMI reduction. 33% of those who lost 10% of their BMI had AF recurrence, 44% of those who did not lose weight had AF recurrence, and 78% of patients had AF recurrence in those who gained BMI. Now, the authors used statistical adjustments, and on multivariable analysis, only bariatric surgery was significantly associated with reduced AF recurrence. They, of course, did propensity matching and even some inverse probability weighting of the two groups, trying to even out these baseline differences and negate the confounding by indication issue. And they found that bariatric surgery remained associated with a reduced hazard for AF recurrence. But the authors rightly state in their limitations that this is an observational study, and although many studies previously show that bariatric surgery can be beneficial, it will take randomized trials to demonstrate that the surgery causes, not just associates with, less AF after ablation. So I joined Professor Sanders and his colleagues who, in an accompanying editorial, pushed back against the author's final sentence in this paper, which stated that all morbidly obese patients should be considered for bariatric surgery before ablation. This data clearly does not support that strong of a conclusion. But the main strength of this paper is that it confirms the benefits of weight loss before ablation, which might be accomplished with or without surgery. Finally, I applaud the fact that the mean time to ablation of these patients was 22 months. That is exemplary. Too often in the competitive fee-for-service private practice model, the mean time to ablation of morbidly obese patients is days to weeks, which is not enough time to work on the contributing metabolic risk factors. Final topic today is harms from cardiac devices. Researchers from South Australia and Yale have once again added to the extensive but often ignored literature on major complications from CIEDs, or cardiac implantable electronic devices like pacers and ICDs. The Annals of Internal Medicine published this massive observational cohort study of 174 hospitals in Australia and New Zealand. This included 81,000 patients who received a new device. Now, important note, generator changes were excluded, and more on that later. The rate of complications, sit down for this, 8.2%. Now, it was higher for ICDs versus pacers, but since many more devices were actually pacemakers, in absolute terms, most of the complications stemmed from pacer implants. The authors also noted large variations of these complications rates across the implanting facilities. Get this, the complication rate could vary almost threefold. Well, this is important data. First, the variation in sizes and types of these hospitals likely mirror those in the US and perhaps elsewhere. I think this is likely representative data. Second, once again, this study documents a much higher than appreciated rate of complications. I bet almost no implanting doctor tells patients that complication rates from these devices are anywhere near 8%. Now, these soberingly high rates of complications would have been even higher if generator changes were included. And these data were also recorded before the His bundle pacing era, and there's no doubt that His bundle pacing will have higher rates of complications, mostly due to lead reoperations. Finally, while a pacemaker for a truly necessary indication like complete heart block is one of the purest and most beautiful forms of medical practice, I think many pacers are put in for dubious reasons. Pacer overuse flies under the radar. This data strongly supports the medical conservatives' approach to using cardiac devices, especially ICDs, which when used for non-ischemic cardiomyopathy and primary prevention look to be less and less beneficial as background therapy improves. Before I close, I want to make an announcement. This is the first week of August, and that marks the Mandrola family vacation. So next week I'll be on family holiday and will not have This Week in Cardiology, but will return in 2 weeks. So as always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing and leaving us a review so that others can find us. Until 2 weeks, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.